Hello, everybody. Thank you for the invitation to talk about this topic that I'm very passionate about, and I'm sure most of the people in this room must have been faced with this question frequently, if not on a daily basis. These are my disclosures. So the recent update, the 2019 that came out just a few weeks ago, on early management of patients with acute ischemic stroke recommend that those who are successfully treated with mechanical thrombectomy, it might be reasonable to maintain blood pressure less than 180 over 105, what we call permissive hypertension. Although this recommendation is not backed by strong data, there is no randomized clinical trial data to support this recommendation. To understand the practice patterns across the institutions of blood pressure management after mechanical thrombectomy, we conducted this survey of StrokeNet sites. About 60 StrokeNet sites responded to our questionnaire, and we found that the blood pressure management practice across these 60 institutions was quite heterogeneous, especially when it came to patients who received successful thrombectomy, MTK 2B or more. Institutions targeted blood pressures down to 120, 140, and some also practiced the standard of care less than 180. The practice was quite less heterogeneous for patients who achieved no recanalization or partial recanalization, where most of the institutions tended to target higher blood pressure, the recommended less than equal to 180. We took our investigation further to conduct a prospective multicenter observational study, BEST, that was funded by SVIN's pilot grant, ran at 12 institutions and enrolled about 485 patients. And we found that a peak post-MT systolic blood pressure of 158 millimeters best dichotomized outcomes in these patients, and worst outcomes were defined as 90-day modified Rankin score of 3 to 6. Having a single value of peak systolic blood pressure post-MT over 158 translated into twice as odds of having worse outcomes in these patients. However, this analysis was not significant when we adjusted it for pre-specified variables. Absolute risk reduction was 19% for peak systolic blood pressure less than equal to 158 millimeters of mercury for having a worse outcome, resulting in number needed to treat of 6. A particular population of interest is those with incomplete or no recanalization. Dr. Goyal et al. Have the largest cohort of such patients, including 88 of those, and found a U-shaped relationship between post-mechanical thrombectomy blood pressure and outcomes, where they found that both decrease in minimum systolic blood pressure as well as increase in maximum systolic blood pressure, both were independently associated with worse 90-day modified Rankin scores. These findings have been independently corroborated by several of my colleagues. Some of the investigators are in this audience today, where consistently higher systolic blood pressure after mechanical thrombectomy has been associated with worse outcomes. A particular variable of interest is blood pressure variability after mechanical thrombectomy. In a post-hoc analysis of the BEST study that ran at 12 institutions, we found that increased systolic blood pressure variability also significantly associated with worse outcomes. On the graph on the right, we can see systolic blood pressure variability measured by various measures, divided into 3 tertiles: lowest, intermediate, and highest blood pressure variability. And y-axis is the proportion of patients with good outcome, defined as MRS 0 to 2. Highest tertile of BPV is really associated with lowest odds of having good outcomes. Interestingly, the strength of this association was stronger in subgroup of patients with MTK3, and this group had triple the odds of worse outcomes with increased blood pressure variability compared to those with even MTK2Bs 2As or less. There seems to be time-dependent changes after thrombectomy. So the graphs here represent a fitted generalized additive model of about 17,000 blood pressure values within the first 24 hours post-MT in 485 patients enrolled in BEST. We can clearly see that the graphs of blood pressures are separated at time 0 post-mechanical thrombectomy, and they remain separated with those with good outcomes having lower blood pressure values throughout the first 24 hours compared to patients with worse outcomes. There are several limitations of the observational studies that I just talked about. These are observational association studies, and they cannot address whether the relationship of systolic blood pressure with outcomes is modifiable by lowering blood pressure or lowering blood pressure variability. Despite adjustment of our analyses, likely unmeasured confounders are present, and only a randomized trial can adequately address the issue of ideal blood pressure target after mechanical thrombectomy. To address exactly this, we have designed a phase 2 randomized clinical trial, BEST2, to assess the safety and preliminarily assess the efficacy of lower blood pressure targets in successfully MT-treated patients. The trial will enroll 120 patients and randomize them 1:1:1 in the following systolic blood pressure targets to be maintained for 24 hours immediately post-mechanical thrombectomy: less than 180, less than 160, and less than 140. And the trial will assess the effects on infarct volume and 90-day functional outcomes. The trial is registered for public to see. In conclusion, recanalization status should be considered when deciding post-MT blood pressure target. Patients with successful recanalization about 160 millimeters mercury best dichotomizes functional outcomes. It may be reasonable to allow permissive hypertension in those patients without successful recanalization. It is also reasonable to avoid antihypertensive agents that increase blood pressure variability, such as beta blockers, and prioritize using calcium channel blockers, which are associated with lower blood pressure variability. Strict blood pressure control should be maintained throughout the first 24 hours and beyond if necessary, and a randomized trial is currently underway to address the question of ideal blood pressure target after mechanical thrombectomy. Thank you.